So this is our digestive system, and it starts with the mouth and ends with the anus. In palliative care, we come across with a lot of gastrointestinal symptoms, probably a lot. And the most common ones are the most common GI symptoms we come across here are oral thrush, stomatitis, dry mouth, nausea, vomiting, constipation, diarrhea, and intestinal obstruction. So today we'll be learning in detail about nausea and vomiting because it is very common. Most of our patients belonging to the palliative group, not only the malignancy patient, those patients having other life-threatening illness also come across with this distressing symptoms. So we learn in detail about nausea and vomiting. Next slide. So the thing is, what happens usually is that we all know a very few drugs for nausea and vomiting, right? What where we give tablets for. So what we do if someone complains about nausea or if they complains about vomiting, we give the tablet. But here, from today onwards, you have to learn there is something different. Okay, we should know what is causing nausea or vomiting and how can we tackle it. It is not only like a generalized one tablet for every kind of nausea and vomiting. There are different types, there are different causes, there are different treatments. So if you treat properly, if you find the cause properly, you can treat it properly. For that, you have to know about the different aspects. So we learn a little in little detail because when you know the cause, you can explain it to someone. When someone asks you, like, sister, what is the cause? Why does this happen? Why I'm not giving this and why I'm giving that? For all these questions, if you want to reply or if you want to answer, you need to know something about it. Okay, so I'll go a little bit in detail. So, starting with the nausea and vomiting. So, what is emesis? Emesis is defined as a biological defense mechanism to remove a toxic or harmful substance from the body after ingestion. I have shown the picture of a chameleon, right? So, what's the peculiarity of a chameleon? Chameleon changes its color to protect it from enemy, right? So, like that, our body also have a defense mechanism. When you take a harmful substance or accidentally, if you inject something, our body it will inject it out. That is a defense mechanism. Instantly it removes it out by vomiting. So, it is a defense mechanism. So, let me explain. There are three phases of vomiting. Vomiting is not just a single phenomenon. It happens like a three actions. Okay. First one is nausea. Nausea means it is an unpleasant sensation of imminent need to vomit. The patient might not vomit. Okay. They'll have some kind of unpleasant sensation. Sometimes they feel like there is something in the throat, or sometimes they'll feel like something there is in the stomach. So it is an unpleasant sensation proceeding vomiting. So sometimes the nausea can end up in vomiting. Sometimes the patient can have prolonged nausea. Think about patients who are in palliative care, who are receiving chemotherapy. They have nausea for a very long time. Or those patients having malignancy, they have loss of appetite, right? It is a feature. It's a feature of malignancy. The patient will have loss of appetite. They might sometimes have a nausea. They have a continuous nausea from days to like weeks, sometimes to months. So that the first one, that is nausea. Now coming to the second one. Next, nausea is next it is retching. What is retching? Retching means there is a spasmodic contraction of diaphragm and abdominal muscles. Abdominal muscles and diaphragm will contract against a closed glottis. Think about, I know everyone in this group must have experienced at least one episode of vomiting in their life. So think about when you got a vomiting, first you might have felt a nausea, you feel nauseated, and then there comes a retching. You feel like something's coming out, and you feel choked also, right? And here also, this retching sometimes result in expulsion, the complete vomiting, or sometimes the patient keeps on retching. They'll be keeping like, oh, oh. This sound will keep on like they'll continue like that. So this is retching. Okay. The choking feeling is due to the contraction of diaphragm and abdominal muscles against the closed glottis. Glottis means in our trachea. Okay. Now the third one, vomiting. Vomiting is the real one, and where there is a forceful expulsion. It is not like leaking or something. It's a forceful expulsion of gastric content, and that too happen by the contraction. This is the end effect of retching. Sometimes I have already explained retching might not result in vomiting. The patient can like keep on. They can have retching. Also, the patient can keep on having nausea also. Now, the last one, the regurgitation. What is regurgitation? Regurgitation is something different from all these things. You must have you remember about the babies who take milk and sometimes it will come out through their mouth. It is simply because of the since their sphincters are not that tight, so the abdominal contents will slowly come back. There you will not have any kind of nausea. There you will not have retching. So regurgitation is another part. Next slide. Now, yeah, I have already told what is nausea. That is something unpleasant sensation in the back of throat. It precedes vomiting, but it may not always result in vomiting. So, in symptom wise, it is two different aspects. The patient may tell you that I am having vomiting, but there is no nausea. Also, in the reverse, they'll tell I am not vomiting, but I have only nausea, vice versa. Okay, so they can that both of them are two different entities. They can complain as such as nausea and vomiting. Next slide. So let me tell you about few things which you usually come across in your clinical practice, but we don't know what is it, what actually happens. So there are different types. Okay, acute vomiting, delayed, breakthrough, refractory, and anticipatory. You should know what are all these things. Acute means when you take something within 24 hours, you will vomit it out. For example, if you have a food poisoning, if you take such a potent staphylococcal or something, endotoxin bacteria, and all, sometimes there are certain bacteria endotoxin and it will cause vomiting after when you go to a hotel where the food is very bad, you take it and within 24 hours you started having vomiting and later it settled by itself. That is not as acute. Or sometimes in some type of chemo, not all chemo, some chemo after when the patient takes the drug itself, they start having vomiting. Later it will like settle down. Second one is the delay. So that's acute. Okay, the first one. Second one is delay. This is also you can see in chemotherapy patient. The patient takes injection usually occurs after 24 hours of chemo and it will be worse from 48 hours to 78 hours and it may last up to 6 to 70. So here you should explain those patients who are the bystanders or the caregivers of a malignancy patient will tell to you, ma'am, see my brother or my father, he took the chemo injection, he's getting vomiting after 2 to 3 days. That is known as delayed vomiting. Yeah, that will be there after taking injection. He will get the vomiting after 2 days. That is known as delayed, and it may persist for it can persist up to 6 to 7 days. It will later settle down. You should be able to reassure them, telling that yeah, this is there. Okay. Now, what is breakthrough? The third one. Breakthrough means you are giving an antiemetic. Okay, a patient comes to you and you are a sister. You give some tablets, antiemetics and the vomiting reduced in spite of giving medicine also he had 2 episodes of vomiting. That is known as breakthrough. That means you have heard about breakthrough pain, right? When a patient having pain, we give morphine. A patient will be having round the clock relief, but sometimes he'll get a pain. That is known as breakthrough, breaking through. So that is also here applies here. That is, even if you give medicines, patient is on antiemetic, but still he has 2 to 3 episodes. Not very prominent, but occasionally they get some 1 or 2 episodes. That is known as breakthrough. Now the fourth one is refractory, unmanageable. You give anything, nothing is going to happen. The patient is like having continuous vomiting. That is known as refractory vomiting. Now, the last one, anticipatory. You might not have heard about it, but there is something called as anticipatory vomiting. Okay, at least someone must have encountered it. Have you heard about some bystanders telling, say, for example, madam, my father is he's planned for chemo on Thursday. but he gets vomiting starting from Monday. I don't understand the logic. Is he trying to what is happening? Is he trying to fool us? Something like that. People will ask like that because the patient, for them it will be like chemo will be taken only on Thursday, but he starts developing vomiting like 3 days before he gets chemo. How does that happen? That is known as anticipatory vomiting. We'll talk about it in detail little after little time. Anticipatory means the patient, the thought of getting chemo induces in the cortex, the brain, no, brain will act. So the thought of getting chemo on Thursday, the patient will anticipate. They'll have the fear that they'll get vomiting and they start vomiting. So these are the different types, like different timings. Okay, the vomiting can occur in all these fashions. Okay. Now, coming a little bit, you learn about the causes. You should be able to tell them, see, this might be the cause. There are so many causes for vomiting, and these might be the cause. For you to know that, you should know what are the causes of vomiting. Okay, next slide. So, first one is a chemically induced nausea. Okay, the drugs, causes like drugs, antibiotics, cytotoxic, toxins, ischemic bowel, gut obstruction, and metabolic organ failure. Coming to the opioids. See, morphine, you know, no? Morphine has a side effect of causing nausea and vomiting. Antibiotics, you know, it can cause gastritis, and in turn, it can cause nausea and vomiting. Cytotoxic drugs, like chemotherapeutic drugs. Okay, all those can cause nausea. So, chemically induced means drugs causing the problem. Toxin, the toxins by food poisoning and the ischemic bowel, gut obstruction, the level of ammonia and all will increase. It will act, it's a chemical induced nausea. And metabolic organ failure. Okay, when the patient have uremia or hepatic failure, uremia, the patient will get, that is a kind of metabolic organ failure. Okay, so all these can cause vomiting. Next one, gastric stasis. What is happening? Anticholinergic drugs like amitriptyline, all those drugs, they will have anticholinergic effect. That is gastric stasis. They will not cause the abdomen to move. So the food content will be there in the abdomen, they will vomit it out. They'll have nausea. There will not be proper digestion, and the patient can vomit it. Patient having ascites, dyspeptic ulcer, gastritis, all those things. Okay, read the other things. Fracture, distortion of the GI tract, like constipation, intestinal obstruction, mesenteric meds. The food contents or the bowel, the stool will stay in the feces will be staying in the uh, or alimentary canal, and it can stretch the abdominal wall and it can cause vomiting. Since it is not going down because of the obstruction, it can come up through your mouth and patient can have vomiting. Okay. Then irritation of GI tract, raised intracranial pressure, something on your head, brain tumor, brain malignancies. It can increase the pressure, brings pressure inside the brain, space occupying lesion, malignancies. So all these things can cause other causes of vomiting. So when a patient vomit, you should have a photographic memory. Okay, you should have this slide in your mind, and you have to rule out each one. Maybe this one, maybe this one, it could be this one. So you have to ask all these things. The last 2 points are also very important. Movement associated vestibular disorder. A patient or not a patient, even you all when traveling in a bus or a car for a long journey, in a hill station to a hill station, you get vestibular disorder, right? You get that motion sickness. A lot of histamine will be released, and you will get nausea and vomiting. Anxiety induced, as we told, anxiety, anticipatory vomiting comes under this one. So all these are the different causes. Okay. Now, how will it affect our patient? See, think about a patient who is having vomiting continuous 24/7 in a week, lasting for months. Is it a good thing? No, definitely not. It will affect the quality of their life. They'll not be able to take food. They'll not be able to go out. They'll be sick. They'll be having very tiredness. They'll be not able to take any kind of fluids or water, and all those problems will come. it will affect the daily functioning. And what happens? Eventually, what happens? Sometimes there is not complaints to cancer treatment. You know what happens? Some type of malignancies where they diagnosed it very early and they tell to take 5 cycles of chemo. After the 2 cycles, sometimes they will stop the chemo. What is the reason? They'll tell that, oh, doctor, see, I took 2 cycles and it was very disgusting. I don't want to get this kind of vomiting. It is very distressing. So they'll stop the chemo. Those patients who can be saved, they'll stop the chemo and they'll go back and die. So we have to control this. This is a symptom which we can control. So we should be able to assure them. So also like they deny the cancer treatment, they also deny the analgesic. Patient having pain, also having vomiting. Because of vomiting, they'll not take this analgesic. They'll tell, oh, see, I'm vomiting everything and you are giving me too many tablets again. He'll get vomiting again and he'll get the pain also. He'll be in suffering. So these are the problems of when the patient have continuous vomiting, poor fluid or oral intake, family will also be in distress. All the family members will be in distress most of the time. We see a lot of patients, caregivers, when their kith and kin is affected, when your husband is affected, when your mother, father is affected, they tell that, doctor, see, they are not taking any food. How can we take the food? How can we see him suffering like this? It's so much suffering. Somebody is continuously having nausea and vomiting. So this is the problems of social problems of having a vomiting. So our goal. So what should be our goal? Our goal is to stop. Sometimes that may not be possible. At least to reduce the symptom frequency or to establish a compliance to the treatment. That is our aim. We should be able to tell that, see, your chemo is causing vomiting, but we'll be able to control it. Try to continue the rest of the cycle. We are with you. We can control. We'll try to control the vomiting. We should be able to tell that. Okay, we should be able to control their symptom. And also, this also helps them to enable analgesic, take analgesic medication, pain medication. They'll take all other medications and to improve, eventually to improve the quality of life. So management, see, like I told in the beginning, most of the patient, nearly 40 to 70, look, 70 is not a small number. More let's slide up. Yeah, 40 to 70 percentage of patients with cancer itself, not only the palliative patient, the cancer patients will have nausea and vomiting. It's a very high number. We have to manage it. And here, like I told, management involves accurate assessment. We should take a proper history. We should understand what is the cause of this vomiting, not like throwing and like antiemetics. So we'll get a good control of symptom and we'll get a next and we'll study about the antiemetic drugs. So for an accurate assessment, we need to study the causes, we need to study how they work and how the drugs act. So we are coming to slowly coming into the drugs and all. Okay, next slide. So, like the principle, every time we tell, we should correct the correctable. Sometimes there'll be something like if the patient might have been having a very big infection, try to control it with antibiotics. Certain things where we can control. That's what correct the correctable. Now coming to non-pharmacological and dietary modifications. Jumping on to the before jumping on to the medical management, we'll do something like non-pharmacological methods where you can learn it. Okay, these are very important for you. You can tell some small techniques for them to reduce the nausea and vomiting. Next slide. The non-pharmacological measures include avoiding situations like sometimes these malignancy patients or patients having nausea, the sight or smell of food or some kind of what wound or fungating smell, malodor, all these things can stimulate or increase their this thing to nausea. So avoid situations exposing to such kind of environment, calm and reassuring environment, fresh air, and nurse in the upright position. Ask them to sit and take food. maybe lying down and had taking food, the patient might get more nauseated, or the proper digestion will not happen. Control of malodor, that is very important. Okay, imagine a patient having colostomy or a fungating tumor near the neck or head and neck tumor, where the patient himself sometimes get the smell of this, all these bad foul smell, and they'll not be able to take the food. So control, manage the wound accordingly, control the order of the food. All these are very common. Okay, this is not very uncommon. We see a lot of patient here, those who are having colostomy, and those who are having fungating wound, because of the smell they don't take food and they feel nauseated. So we can use, there are I know you have a special, you have a different class about wound management, right, where how do we manage a fungating wound and all. So there you have to study on how to control the malodor of these wounds. Now, next, dietary modifications. This is also very important. If somebody is asking our patient that take food, he's not taking food, if they're forcing, keep on, already the patient is having nausea. Okay. And into that, you are forcing, take food, he's not taking food, you drink water, you drink milk, you drink this, that will only put him down. Okay, he'll stop whatever he was taking also. So what you can suggest is that you should teach the caregiver that you can give small but frequent meals, little meals in a frequent interval, so that he'll not get that kind of aversion to food. Avoid fatty, sweet, spicy, carbonated. Most of the patients will not be taking all those things. Already they'll be like gone to all other food and they'll not be taking this. But you can suggest them, don't take this extra fatty or the too much oily food and all. Take plain food and small frequent meals. Now coming to the pharmacological measures. This is a very important topic. This is a very important topic, and this from here only we learn what are the problems, what happens in the brain, and what medicines we are giving. So these things will be little difficult for you to understand, but I'll tell it in the most simplest way for you to learn at least few things that have to be in mind. Okay, so listen carefully. If you listen in between, you will not understand anything. So listen, it's very simple. It's actually very simple to understand, only you have to listen carefully. So, this is a brain, and for anything to happen in a body, if I'm moving my hand like this, if I'm moving my head like this, everything is controlled by the brain, right? So, a vomiting, when a vomiting, someone should vomit, we have a vomiting center which is located in the medulla. Okay, we have a vomiting center in the medulla, and next slide. We got a lot of receptors also. Okay, in our brain we have a vomiting center, and there we have a lot of receptors also. So what happens in the vomiting center? Some stimuli will be there, and it will send action potential to the vomiting center, and that's how we get vomiting. The vomiting center itself cannot cause vomiting, so we should know what is the thing stimulating the vomiting center. We learn next. So before that, you have to learn some receptors. Okay, these receptors are very common, and these are the these receptors play a vital role in causing vomiting. So the cholinergic receptor and their short forms. Okay, if you when I'm switching to the other slide, don't forget this. Cholinergic receptor, it is M1 receptor. Dopamine is given as D2 receptor. Histamine, in short, we'll tell H1 receptor. Substance P is the receptor is NK1. Serotonin 5-HT3. This is very important. Serotonin is 5-HT3, and mu is Mu, that is a mu receptor. So these are the receptors. I'll tell you where these receptors and how they act. So just know about this. There are different receptors, and the vomiting is controlled by the vomiting center. So yeah, see, this is the vomiting center. As I told, the vomiting center itself cannot cause vomiting. They need some stimuli. See, I have shown four different stimuli. One is from the GIT. Next is from the cortex of the brain. See here, cortex of the brain. Next is the chemoreceptor trigger zone, CTZ. This is also very important, and the vestibular system. See, from all these things, they'll send stimuli to the vomiting center and the patient will get vomiting. So let's start with the chemoreceptor trigger zone. Okay, from the chemoreceptor trigger zone, it is a zone. See, zone means so many things are together. So in the chemoreceptor trigger zone, it is also located in medulla. Okay, there are a lot of receptors. So when these receptor get stimulated, the CT set gets stimulated and it will send impulse to the vomiting center. In the ear, when you are traveling, when you have a motion sickness, the vestibular system is affected and there some kind of histamines will be released. And that will in turn, we have the M1 receptor and histamine receptor. So it will affect the vestibular system and it will send impulse to vomiting center and that's how we vomit. In the GIT, when you take some chemotherapeutic drugs or when you take some food and all, the GI system will send a stimuli to the CT set and from there to the vomiting center. Cortex, the sight, smell, all those things will send stimuli to the vomiting center and you get vomiting. So in detail, starting with the chemotherapy, how chemo patients get vomiting. That's what we are going to learn here. Okay, why this chemo patients and those patients receiving radiotherapy get vomiting? You know what happened when they take some chemo drugs? No, it will go to the intestine. It induces a release of serotonin from the gut wall. So when a patient take chemotherapy drug from the gut wall, they'll release the serotonin. So we know that, see in the previous slide, see in there is a chemoreceptor trigger zone. This is a chemoreceptor trigger zone, and there you have serotonin. I told 5-HT3 receptor. So what happens is from the gut wall, the serotonin will be released and it will stimulate the CT From the CT it will stimulate the vomiting center. So see the picture in simplified version. From gut to the serotonin receptor, from serotonin receptor to the vomiting center, and the patient will get vomiting. This is the reason. Okay. So here the serotonin is making the problem. So what we give for blocking the serotonin receptor, we give cetrons. We give example of cetron is ondansetron, Emiset, the drug which we use commonly. So this is the reason why those patients getting chemotherapy and radiotherapy get vomiting. And this is the reason why we prefer Emiset. Have you ever noticed? You can check all the radiotherapy department notes and all. After chemotherapy, most of the time the patient will be given ondansetron for controlling vomiting. If you give some other drug instead of ondansetron, it might not work. For that, you should know why this happens. Okay, so in simplified, look at this picture. Induces from radiotherapy, chemotherapy, serotonin will be released from the gut wall. Serotonin receptor is present in the CT set. CT set, it will send impulse to the vomiting center and patient vomits. Okay, hope you understand. Did you understand? Can someone tell yes or no? Are you following? Are you able to follow? Okay, okay, thank you. So that's why we give ondansetron for those patients. Now, what happens in post-operative patients? You have worked in post-op ICUs and all, no? Post-surgical wards and all. Patient will get vomiting. Why is that happening? See, during the surgery, the surgeons and anesthetist and all will give some opioids to control pain. Our opioid, morphine, fentanyl, all these are given during the time of surgery. And what happened? There comes the next receptor. So during the surgery or during the there will be administration of opioids like fentanyl, morphine and all. So what happens? These morphine and all these drug will stimulate the D2 receptor in the CT cell and mu receptor. We know that opioids act on the mu receptor, right? Opioid. When we studied about morphine, we have learned, right? Morphine acts on or opioids act on CT cell. Like that, these opioids can stimulate the D2 receptor, dopamine. D2 is dopamine. Serotonin is 5-HT3. Okay. So what happened when the D2 receptor in the CT cell? The previous slide, go back to this previous slide. See here, there we have 5 in the CT set, we have D2 receptor and 5-HT3 receptor. So from the GI, 5-HT3 was stimulated. But from this post surgery, what happened? Mu receptors and D2 receptors in the CT set is stimulated. So what will we give? We should block the dopamine, right? So we give a dopamine antagonist. So the example of dopamine antagonist are metoclopramide. Metoclopramide we can give. Domperidone we can give. And mu receptor agonist. What is that? Haloperidol. Haloperidol act against the mu receptors. So that's why in post-operative patients we give metoclopramide. We give perinom, very common drug, right? Perinom is metoclopramide. So that is the reason why we give it. So in post-operative we give opioids. It stimulates the D2 receptors in CT set and mu receptors because anesthesia doctors will use opioids for controlling pain. So mu receptors and it results in vomiting. So we can give either an anti-dopamine. Anti-dopamine example is domperidone, metoclopramide. We commonly use post-surgically, we use metoclopramide. This is the reason. And we can also, for blocking the mu receptor, we can give haloperidol. That we'll discuss in detail. Now, the vestibular apparatus, I told you already, vestibular apparatus is our ear balance. When you are traveling, you get motion sickness. What happened in the ear? A lot of histamine will be released and it will act on in the ear. You have the picture, the previous picture, the picture that you have to keep in your mind. See the vestibular system, you have the histamine receptor. See, histamine receptor, vestibular system is stimulated, it sends action potential, histamine is released and H1 receptor is affected. And we give, for that what we give? Very simple, antihistamine. If histamine is causing the problem, we have to block the histamine. If dopamine is causing the problem, we have to give an anti-dopamine, like a dopamine antagonist. If serotonin is causing the problem, we have to give a anti-cetron, that is ondansetron, for example. So here you can give antihistamines. Now cerebral cortex, here see, look, taste, smell, sight, memory, all these can affect the cortex of the brain, the cortex part of the brain controls all these things. So our anticipatory vomiting, we told no, patient going for chemo on Thursday, but getting vomiting on Monday. If you give Emisec, will it work? Will it work? Is it because of the serotonin? No, it is because of the cortex of the brain, the sight and smell, all those things. So, what you have to do? The treatment for this one is different. You can give an anxiolytic, you can give a benzodiazepine to control the cortex. You can give a lorazepam or clonazepam, Alprax, all those kinds of things are anti-anxiety drugs. That's how we have to manage vomiting here. In such type of patients having anticipatory vomiting, if you give ondansetron, it will not work. Okay, the patient will get fear again and again. They'll stop going for chemo. But otherwise, if you know this concept of having the patient is getting anticipatory, like vomiting because of the cerebral cortex, a patient is having the fear. It is because of fear. If you give a clonazepam or if you give a lorazepam, it will settle. If you don't give ondansetron, nothing will happen. You have to give this one. This is the treatment for this one. So this is the importance of knowing the cause of vomiting. Now, in short, I'm just telling it again and again. So in chemotherapy, anesthesia, opioids, all these things triggers what? The chemoreceptor trigger zone. In what happens in chemoreceptor trigger zone? In the trigger zone, there are a lot of receptor, dopamine receptor, 5-HT3, opioid, all these. Zone means all these receptors are clubbed. Okay, so they anything happens, they'll send impulse to the CT cell and vomiting happens. bad smell side, all those things. Cortex, the front cortex, fear, anticipation, and vomiting we center is stimulated. What we have to do? Benzodiazepines. Benzodiazepines example are clonazepam, lorazepam, and all. Okay. Now, again, the same thing from the gut, what happened? From the small intestine also, they have receptor surgery, chemo, same thing. I'm telling the same thing for you to understand and make it very clear. Okay. Now, the examples of drug. So, M1 receptor blocker in the ear. Okay, vestibular system. I told there will be release of histamine and so much of cholinergic and all. So, in order to block that, we give hyoscine or we give. Have you ever heard about this thing? Avomine. We give tablets, right? We give tablets for those patients traveling to prevent the motion sickness and all. So that is his H1 and M1 receptor blocker. Okay, antihistamine and acetylcholine blocker. That is promethazine, diphenhydramine and all. These are the common ones. Okay, hyoscine, dicyclomine and all you know. Cyclopam. Cyclopam is dicyclomine. Okay, now dopamine receptor blocker. The examples is metoclopramide, perinom, very common drug. Perinom and domperidone. Like all these things you will use, right? Now, serotonin blocker is cetron. Example of cetron is ondansetron. Okay. So many new drugs also there. Ondansetron is a common one. Neuroleptics means our what opioids. Okay, like morphine and all. For we give neuroleptic mu receptors are activated for blocking the mu receptor. Who is there? Haloperidol, haloperidol or chlorpromazine. And substance P, the receptor blocker is aprepitant and rolapitant. These are newer drugs. It is really costly and all. We don't need it very commonly. These are also there. So you should know the drugs. Okay, how it act, what is the problem, who is it blocking. Okay. Now this is a complicated slide. I have already explained this. If you look into this, you will understand what we told. This is a gist of what we told. Okay, chemotherapy, anesthesia will affect the chemoreceptor zone, and it will affect the vomiting center, reflex, higher cortical center, memory, fear, anticipation, all these things. Benzodiazepine. You can take a picture of this slide, or you can keep it. If this is different, any of these slides, you have to one of this slide you can keep it in your mind. Okay, if you know that, it will be very easy. Now the same thing what we told, in who all, in the chemoreceptor trigger zone, what all things will stimulate, like we told, opioids, chemotherapeutic drugs, biochemical, increased hypercalcemia, it will affect the CT set, or the renal failure when the amount of urea is increased, ammonia increased. All these will affect the chemo CT set. Liver failure when the patient have high SGOT, SGPT value, bilirubin, everything will be increased. That is a when the patient have liver failure. Sepsis, patient having sepsis, severe sepsis, infection, it will directly affect the CT cell. And radiotherapy, like we said before, through the serotonin. Now, vestibular system, it can be because of the antihistamine. Again, tumors, sometimes the tumors in the head or the opioids can also stimulate the vestibular system. Cortical system, anxiety, ICP. When you have a very big brain tumor, cortical cortex is involved. There also you can get this thing. Peripheral is the one I told, the GIT, gut part. Okay, same thing. Radiotherapy, chemotherapy, all these can induce the serotonin. GI irritation is also there. When you take NSAIDs, all these things and all, you can get gastric irritation. Hope you understood this part. Are you clear? Is it clear for you all? It is little bit difficult to understand, but I have told in a very simple way. Hope you got it. You can ask doubts if you have. You can read once again. Okay. Maybe if you hear all these things in the first time, you will not be able to digest the whole thing. Learn about it a little bit so that you can answer others. You'll know why you are giving it. Okay, now you have learned about everything. Now to finish, okay, the receptor part, everything is over. Now we are going again to the other part. So, what is it? Drugs. you should not like, there is no rule like you have to give IV route or for vomiting, nothing like that. As per the patient condition and preference, if the patient is taking drugs orally, um, you can ask them to, you can allow them to take oral tablets. Okay. Oral route is the best and easiest. Okay. You should not act, you should not tell them that, oh, you are having vomiting. You can't be kept at home. You come to hospital, we'll take some injection. Nothing like that. If the patient is able to tolerate oral food, you can give it like that. Okay. But if the vomiting is severe, he is not able to take at least one sip of water, you can give IV. Otherwise, there is no rule that you have to admit the patient, you have to give only IV route. You can give oral tablets. You can manage with oral tablets. Okay. In other countries, foreign countries, suppository, sublingual, transdermal patches, all these things are available. It's not very common here. We have, most of the time, we have only oral tablets. Okay. Now, next one. So, in short, the treatment, our treatment should be mechanism based, okay, and not generalized. From today onwards, it should not be like if you have vomiting, you have one, you throw one tablet. No, don't like, not like that. You have to ask what is the problem. You have to ask history, whether the patient is taking chemo, they have traveled, or some what kind of drug they are taking. All these things should come in your mind. Okay, and the very common drug, which is a very common drug causing nausea and vomiting in our palliative care. The common drug, I've already told. Can someone unmute and answer?
Morphine.
Yeah, morphine. Very good. So, drugs causing nausea and vomiting, how it acts is, our morphine can has direct activation on the CTs. That's how it causes, that we already told, right? Morphine acts on the mu receptors on the CT cell. Also, there are certain drugs like causing gastric irritation. Give example of a drug causing gastric irritation. Very common drug causing gastric irritation. Please unmute and answer. Very common drug, not in palliative care. Wherever you give, the patient can have gastric irritation. Come on.
Di-
Yeah.
Diclofenac.
Yeah, diclofenac, very good. Diclofenac comes under NSAID. Yeah, correct, very good. Brufen, NSAIDs. So NSAIDs can also cause gastric irritation, and that can cause. So these are the drugs. The drug wise, you have to think about your concentration should come across opioids, NSAIDs, and all. Okay. And this uremic, like biological causes that we already told, all these kind of metabolic problems, uremia, hepatic failure, ketoacidosis, hypercalcemia, toxins, these are the biochemical causes. The other one was drugs. This is biochemical causes. These also cause a stimulation of CT cell. Now, raised ICP. This is a different scenario, okay? Raised ICP, like I already told, the patient will have a brain tumor or a space occupying lesion. The pressure inside the brain, raised intracranial pressure, the patient will get nausea and vomiting. Here, the treatment is little different. You know how? You know, every tumor, they'll have a peri-tumor edema. There will be a very peri-tumor edema. So here you can use steroids. That is the best way of managing patients having patients having raised ICP will have headache. Okay, the raised ICP will have headache and vomiting. So that kind of vomiting vomiting can be controlled with steroids. Okay, that's how. Steroids are potent anti-inflammatory, like Dexona and all. Dexamethasone is an example of steroid. So when a patient comes with a tumor in the brain tumor or brain malignancy, you can go for steroids. Okay, or radiotherapy. Sometimes radiation can help increase the size of the tumor, and that's how also we can reduce the nausea. Here, if you give one time citron, will it work? No. Understood? If you give a patient having brain tumor coming with nausea and vomiting and you are writing ondansetron TDS for 3 days, will it work? No. So you should know why that is causing vomiting. Patient is having raised intracranial pressure. Now, yeah, see, this is about anticipate the need while starting morphine. I'm talking a little thing about morphine because most of the time we have to prescribe morphine. We already know that morphine is an opioid and morphine can cause vomiting, right? So we have to write some kind of antiemetic when you prescribe morphine. Okay, you know that morphine causes constipation and you write bisacodyl along with stimulant laxative along with morphine. Along with that, you have to start antiemetics also. Prophylactically, you have to tell the patient that, see, I'm going to start morphine and you can get vomiting if you when you start morphine. So prophylactically to avoid that, we can give an antiemetic for few days. You can take antiemetic for few days like 3 4 days 3 days. So this anticipating the need, you should not like tell them that you take this tablet when you need it, okay, when you get vomiting you take it. That will not work here. The SOS dose, the PRN dose, that is not going to work here. We have to give regular dose. Okay, we should anticipate that the patient will get vomiting and we have to use a adequate and regular dose. It is not SOS dose. So, yeah, receptor involved, like it already told, like, oh no, the previous slide. Yeah, the last two things. Combinations if necessary. What is combination? Sometimes you use one drug, okay, you use ondansetron TDS, and the patient is not getting a good relief. Then you have to add certain other antiemetic also. That is according to the need. Okay. Mm, For example, a patient having a brain tumor, you also the patient is on opioid. So we'll start the patient already on metoclopramide. This thing is not controlling, and then you have to go for steroid. You can use both. That is a combination. Not like every time you have to add two drugs. Only if the first drug is not, you feel that the first drug is not efficient, you can add one more. Only after proper assessment and testing. Back, back, back. Anticipate alternative routes. Okay, you should keep this in mind. You are trying to give the patient is taking orally, but he is able to tolerate oral drug. But later, after sometimes his condition may deteriorate, and you have to switch to some other route also. So you have to keep all these things in mind. Okay, anticipate the need. You have to use a adequate and regular dose. You should not use a underdose. You should correctly properly write the medication like a receptor involved, and you can use combination of drugs, combination of antiemetics if necessary, and anticipate alternative routes. Now, antiemetic, I'm telling a little bit in detail about the drugs. The few things you need to very commonly use drugs. Okay, dopamine antagonist is D2, antihistamine. Now, I think you know this. No, I have told it like 100 times, nearly 100 times I have told. Antihistamine is H1, anticholinergic is M1, serotonin antagonist is 5-HT3. So let's learn a few things about metoclopramide. Metoclopramide is a wonder drug. Okay, it is a very good drug. We use it very commonly because it has three actions. Look, it not only it is a D2 antagonist, also it has two more actions. Look, it has 5-HT3 antagonist. It is having slight 5-HT3 antagonist also. Also, it has a cholinomimetic property. What is cholinomimetic property? Cholinomimetic property means it helps in increasing the prokinetic movements. It induces a peristalsis. And that is helpful, right? A patient having a feeling of fullness, nausea, vomiting. If you give a drug which is helping the food to digest very fast, he'll feel very light-weighted, right? So these are the good things about metoclopramide. It acts by three methods. Metoclopramide is a D2 antagonist. and the dose comes from 30 to 120 milligram. But how do we start? We start with 10 milligram TDS. When you write morphine, you can start metoclopramide TDS for 3 days. Okay, you can increase the dose up to 120. Eventually, sequentially, you can increase up to 120 milligrams per day, and the duration of action is about 6 to 8 hours. One, if you give one tablet of metoclopramide, it will act for 6 to 8 hours. So this is about metoclopramide. It is very important. We use it very commonly, and you should know why this is preferred. Haloperidol. Haloperidol is the second commonly used. Both of them are equally important and good, and this is used. This is also a D2 blocker. Okay. Examples of D2 blocker include metoclopramide, domperidone, and haloperidol, right? So haloperidol is a D2 blocker. It is an antipsychotic drug. So some people can come and ask you, see, your patient is having vomiting, and you are writing a haloperidol for the patient. Is it right? Then you should be able to tell, see, madam, it is a D2 blocker. It is having its action on CT set directly, chemoreceptor triggers on directly, and thereby you can control vomiting. No, most of the people won't be knowing about this property. Okay, this is very commonly used in palliative care, and you can give this one. So for morphine-induced vomiting, it is a drug of choice. Haloperidol is a drug of choice. Okay, patient is taking morphine and he is developing severe vomiting. You can give a haloperidol. Both you can use. When you start morphine, you can give metoclopramide. In our hospital, we start metoclopramide. Okay, we start metoclopramide for 3 days. Otherwise, you can give one single dose of haloperidol. So when someone asks you which is the drug of choice, morphine-induced vomiting, opioid-induced vomiting, which is the drug of choice, you can write haloperidol. Both you can use metoclopramide and haloperidol. Why? It directly acts on the CT cell. So see, in which all place you can use haloperidol in uremia, renal failure, hepatic failure, all these things causing vomiting, because all these things are acting on the CT cell, right? So our haloperidol is also acting on the CT cell. So the dose comes 1.5 grams to 5 milligrams per day. So what we do is we can give a single dose of haloperidol, or we can give for 2 days. This is for morphine induced. Maximum dose of haloperidol in one day is like India give up to 20 milligrams. We don't go up to also section, but you should know we can give up to 20 milligram. Okay. The patient is having opioid or morphine induced vomiting, you can give haloperidol. Now, we are nearing the end of the class. So, when somebody comes with vomiting, you have to properly document in your case sheet. What are you suspecting? Is it a gastric stasis? Opioids can cause gastric stasis. You don't know, right? So, are you suspecting obstruction, or is it because of the biochemical like hepatic failure? Or is it because of raised ICP? You have to have a differential diagnosis. All these things. Then, if it is not, you have to go for the next thing. So, document the likely cause. Then only you can move forward. Okay. Next. So also these are also the other causes of vomiting. Severe pain. A patient having severe pain might can have nausea. No other problems will be there, but only pain, severe pain can cause vomiting. Infection, cough, continuously coughing. A patient is continuously coughing, and at the end of the coughing, he gets vomiting. In such kind of pain, can you give ondansetron? No, you have to control the cough. The cough is causing the vomiting because the patient is getting a vagal stimulation, and the continuous coughing, he gets a vomiting. Okay, hypercalcemia. All these things you have to keep it in mind. Constipation, increased level of ammonia or urea, intestinal obstruction, nothing is going down. So all these things can cause vomiting. These are also there. These are also the causes. So In short, the most appropriate. Always prescribe the most appropriate based on receptor. Write the stat dose, regular dose, and SOS dose. Okay, stat dose is to control vomiting at that time. Regular dose is to prevent vomiting for 3 4 days. We are giving it prophylactically. And SOS dose for breakthrough vomiting. We told no in the beginning. In the beginning, we told breakthrough vomiting. So to control that, you can tell we can take SOS doses. A patient having taking metoclopramide continuously for tedious, he can take SOS doses at extra. Use parenteral route if continuous the patient is not able to take it orally only, you go for IV. Next one. And also like a single antiemetic may not be adequate. For example, raised ICP, you might sometimes you have to use a dexamethasone along with haloperidol. There is nothing like you can only use one. You can use two, but very cautiously early. Okay, only if it is needed. Don't simply jump into. You can write two and it will be very effective. Nothing like that. You go for one. If it is not working, you go for a combination. So drug induced, the in short, drug induced, the drug of choice is haloperidol. For radiotherapy and chemotherapy, the drug of choice is ondansetron. For metabolic, again it's haloperidol. For raised ICP, it is dexamethasone. If the patient is having delayed gastric emptying, stasis, gastric stasis, you can give a metoclopramide because it is a prokinetic. It will increase the gastric motility. Gastric irritation, we can give Pantop is pantoprazole, proton pump inhibitor, stop irritants like NSAIDs, and just anxiety induced, you can give benzodiazepines. Lorazepam, you can give zero point 0.5 to 1 milligram. Or Clona, I told, no? Anxiety induced, there is no point in giving this thing. Next one. Review the patient after 24 hours. Not like you prescribe and you send them away. You have to review them after 24 hours. You have to see whether it is working, whether the drug you have given is working. And if you need, you have to adjust the dose, use combination. See, most of the time we may require two drugs and revert back to oral from parenteral if symptoms subside. The patient, when he's able to take food, convert from IV to IV to this thing. Two slides back and once. The opioid induced is also very important, different mechanism. CT set because it act on the chemoreceptor trigger zone, vestibular activity, stasis, constipation, all these things. When you use a opioid, these are the problems. So, drug of choice is a metoclopramide or haloperidol. You can give both. Okay. Prevent with an initial. Whenever you start morphine, don't forget to write the antiemetic, metoclopramide, 10 mg, TDS, and SOS. And that's where we come to the end of the topic. Okay, hope you understood something. If you have any doubts, please ask. In your exams, you will get a lot of MCQs. Okay, which is a drug of choice for if you at the end. So many questions will come from this vomiting part. Which is the drug of choice? Which receptor is it acting? What is the drug of choice for anticipatory vomiting? Like that. Okay, what is the dose of haloperidol? Haloperidol is 1.5 milligrams, right? Please share your comments if you have any experience and all. Please share any comments, questions.
Please have an active participation. Please feel free to ask her your doubts.
No doubts? All happy? All done? Everyone can manage nausea and vomiting now? Okay, then let's move on to the presentation, right?
Okay, I think baby day is ready to present. Are you there, baby day?
Yes, ma'am.
I'll share the screen.
Yes.
Baby day, now you can start.
Yes. Thank you, ma'am. And baby day. Next slide, please.
Yes, we can hear you.
Yes, yes.
Go ahead, baby day.
Yes, ma'am. My patient is 61 years old, male patient. Diagnosis cholelithiasis with choledocholithiasis. Next, please. Slide, please. Present. Next slide, please. History of illness. Patient come to emergency for ERCP, endoscopy, retrograde cholangiography, cholediciosis. Next slide, please. Examination, consciousness, temperature 19.6 Fahrenheit, blood pressure 110 by 70 mm of Ag, pulse rate 378, respiratory rate 22, SpO2 98%. Next slide, please. Treatment and signification. Hemoglobin 10 gram, usual to 20,000. Total count, sorry. PG 12.6 seconds. INR 0.94 seconds. PH pre-anesthesia checkup. Next slide, please. Psychosocial aspects. 61 years old married woman living with his 55 years old wife. He has one handicapped siblings and he has one 18 years old daughter. Now his wife is a manual alone and she is taking care of him. He was only earning person on his family. He is a farmer. Have taken 1 lakh from private finance bank for his treatment for purpose. Next slide, please. Medication, tablet Udiliv 300 milligram BD, injection on them 4 mg IV SOS, injection ECM 1 gram IV SOS, injection 1040 mg IV BD, injection Pixo 4.5 gram IV PDS. Next slide, please. Main concern pain relief or decrease in jaundice. Next slide, please. Summary. 61 years old man with pain abdomen, vomiting and jaundice caused of CVD, common bile duct stone. A decrease in jaundice by ERCP, endoscopic retrograde cholangiography procedure. Now he relieved to pain and comfortable. Next slide, please. Discussion points. What all can be done for this patient and his family? Next slide, please. Thank you.
Yeah, so you should tell me what all can be done for this patient and his family. So, what are the main problems he had? Was he having severe pain? Was he having
Yeah.
severe pain, very severe pain?
No, no, ma'am. Moderate pain. Moderate pain.
Yeah, here in this scenario, see, few things we have to notice. One thing is the patient is having jaundice in problems. He was having the TC count was elevated. It was nearly 20,000, right? So the patient might be having an infection. So here might be the pain could have been caused like caused him vomiting, or it could have been the infection. Hmm? Or the high level of jaundice, the liver failure can even cause to liver failure. All these things can might have caused the jaundice. So what we can do is sometimes for this acute conditions, it's not a malignancy patient or something like that. So here it is an acute situation. We can manage
No,
accordingly. What is
no.
the what is causing the problem? It might be when the infection resolved, he'll be okay, or when the pain resolved, he might be little more okay, and like that. Okay, but this scenario is different, and the scenario we see in a palliative patient who is having a life-threatening illness will be different. So we have to manage accordingly. Any comments? Anyone has any comments? Have you come across any patients with? Please share your experience if you have seen anyone with intractable vomiting, how you manage. Anyone? Feel free to talk. Nobody is going to kill you over here. You can talk very freely. Any patients you have seen, anything you have managed wrongly, like think anything like that. Nobody. You all were writing different tablets for vomiting. Is it like that? Oh, very good. This batch is very good. They already knew about the different receptors and all. So nice. Okay, see, please keep this in mind. My message is only this. You have to know about the cause and treat accordingly because it is a very big suffering. I'll share one experience, my own experience. We had a patient who was having some CS stomach. Okay, so he was in his advanced illness. He took medicines, he took some chemo drugs. After that, he stopped as he was not tolerating. So his family, all his family members were doctors. Okay, so they tried all medications, and he was brought to our hospital here, and he was in severe distress. Okay, he was completely out. He was totally out because he was suffering since very long. He only wanted to die. So what we did was we started him on. Patient was also on morphine. So we slowly tried to talk with him, and we tried to understand what was the problem. We tried with the metoclopramide and all, but it did not work. Then we tried haloperidol after admitting here, and slowly he started becoming little bit better. He slept for one night, and the next day he passed away. But the thing is that he got at least some relief, and he slept. For his family was so happy that they tried, as doctors they have tried all the anti-emetic drug, and after starting halo, like he had a little bit relief. He slept, he was able to sleep, and that was a very big thing for his family members. At least he was very comfortable. So the thing is, like, we have to understand it very early. Might be the disease might have progressed very this thing. They all were in very distressing, struggling. So they were happy. Like actually, they were happy. Like at least one day he was free from like his discomfort, and he peacefully passed away. So that's all about nausea and vomiting. Please share any comments. You have not said anything. Nobody has spoken about anything. At least you, if you understood any points which have struck you, anything like that, please unmute and talk. Nobody wants to speak up. Okay, then we'll wind up the session. Thank you.
Okay, I thank Dr. Nayana for her presence and her wonderful class. And I also extend my thanks to Baby Day for her wonderful case presentation. And I thank you all of you for your presence and attentive listening. Thank you all. We'll see you next week in our 8th session of FCPN. Okay, thank you.
Thank you. Bye.